So, good evening, all of you, and I'm very much thankful to Dr. Sharda Jain, madam, for blessing me always and calling again and again for all these webinars. And I'm very much thankful to all Delhi Gynec Forum for inviting me. Today, we are going to discuss this very important topic, and that is polycystic ovary syndrome. Actually, I'm very much lucky that in the initial days of my life, I could get opportunity to work with Professor Gerald Conway, then for few days with Professor Roy Homburg, and so many stalwarts who actually coined this word, and they were pioneer in the setting the terminologies and technicalities of polycystic ovary syndrome. There was said a student in one college of the examination of FRCOG uttered the word polycystic ovarian syndrome, and she was failed because the examiner felt that array you are not taking the name of the syndrome in the proper way because it has very less to do with the ovary. So the name is not polycystic ovarian syndrome, but it's polycystic ovary syndrome. So from that day, actually, I also got some insights. And then I started reading all those consensus meeting and whatever been told in that. It was the first meeting in 1990. And again, here I would like to stress one very important thing, that all the criterias regarding the polycystic ovary syndrome, they are till date, they are not the guideline, they are not the recommendations, but all are being drawn from the consensus meetings. So it's a very important thing and point we have to understand. NIH consensus conference 1990, they said that either chronic ovulation, not either, chronic anovulation and clinical and or biochemical signs of hyperandrogenism, excluding the other etiologies, should be considered in polycystic ovary syndrome. So initially, while coining this polycystic ovary syndrome, the chronic anovulation was the mainstay. And again, the clinical and or biochemical hyperandrogenism was again mainstay. Sonography was just coming, so nobody has uttered about the polycystic ovary nature of the ovary in these criteria. And then in Rotterdam, the people sat together. Again, I repeat that people sat together round a table and then they prepared this. This was not again with proper research papers, or it was not a proper double blind clinical trials which were thought in that, but it was again a consensus opinion. This is written in the Rotterdam criteria. And they said that 2 out of 3 they should be considered as polycystic ovary syndrome criteria. One was oligoanovulation or anovulation. Second, clinical and or biochemical signs of hyperandrogenism. They kept as it is since 1990. And they again they added, because the sonography was came in the picture, and they added the polycystic ovaries and kept the same exclusion of other etiologies like congenital adrenal hyperplasia, androgen secreting tumor, Cushing syndrome. But here they added that the sonography should be transvaginal. But nobody heard, nobody read it. And then everybody, then by doing the abdominal sonography, even on the adolescent girls, they started talking about polycystic ovaries. Then in between, somebody wrote a paper where they mentioned as a necklace pattern of the follicles inside the ovary. And then it became a fashion to mention that almost on all the reports of the abdomen sonography of almost all females. And suddenly, then it was like, okay, there was nothing and something came. It happened. And then Adams criteria came. And Adams added that, we have to be very careful because these girls, especially those who are with oligonovulation or anovulation or with hyperandrogenism, they are usually obese. They have a big pad of fat, and because of that, the abdominal sonography is very difficult. And those machines, when this criteria came in 2003, then 2012, those machines were not good, powerful machines, not with good frequencies, not with good probes and technologies. How would one comment on those ovaries? And then he added that Adams criteria, and then he wrote about the nature, the appearance of the stroma in it. And then first time he wrote about the ovarian volume, that the ovarian volume also should be considered. But everybody, everywhere in all parts of the world, they were just trying to match all the things together. And it took almost 11 years. Though everybody was saying that infertility, subfertility, chronic anovulation, obesity, everything is like an epidemic. But it took 11 years. And then X-ray came out with international evidence-based guideline for the assessment and management of polycystic ovary syndrome in 2023. And there they gave a very different criteria, and their biochemical hyperandrogenism, where they said that the healthcare professionals should use total and free testosterone. If testosterone or free testosterone is not elevated, then they recommended about androstenedione and DHEAS. Then about the irregular menstrual cycles, they gave us correct criteria that a normal cycle can vary from 21 to 42 days. So if it is less than 21 days and more than 45 days, then only one should consider. But again, they gave the criteria of the age as well in that. So many things changed totally when Esre gave in 2023 the evidence-based guideline for the assessment of polycystic ovary syndrome. Then again, the presence of hirsutism they added in clinical hyperandrogenism, that should be considered predictive of biochemical hyperandrogenism and PCOS in adults. I have kept that red line. But when we started finding out the evidence of clinical hyperandrogenism and the levels of the androgens, biochemical levels of the androgens in India, it was very difficult. Because again, if you all know that free testosterone, we send the investigation, but free testosterone should be measured by the side of the patient, which is not possible at all. Many a times, it happens that even at my place, where I am in the interior of the Western Maharashtra, we take the blood, we send through the courier to the labs in Mumbai or Hyderabad, and after 2 days they assess it and they give the reports. of the hormones, then how we are assessing it in a proper way? And that's how then the Royhamberg and group, even Jerry and group, they said that कि अरे, it is not the free testosterone, but we should give importance to total testosterone as well as to the FAI, and that is free androgenic index. Because in between came Beckham and Coulter method. In between, I will talk on that later on about the image. But in between came so many criterias for the assessment of hyperandrogenism, clinical hyperandrogenism. But again, they were person to person, they were differing. So modified Ferryman-Galloway score came. Again, the newer criteria says it should be 4 to 6, and that will detect the hirsutism. Depending upon the ethnicity, it changes. So all these confusions, they were there. And in ultrasound, suddenly, initially the criteria was 10 follicles of 10 to 12 mm. Then it became 12 follicles of 2 to 9 mm. And now they say that follicle number per ovary should be considered the most effective ultrasound marker to detect polycystic ovarian morphology. They have not uttered the word PCOS, but they have written the word PCOM. And that we have to be very careful. And they say that if the follicle number per ovary is more than or equal to 20 to 0 in one ovary, again that will be considered as a threshold for polycystic ovarian morphology in the adults. Again, I repeat, it's a PCOM. Even the ovarian volume more than 10 or the follicle number as said more than 10 in one ovary in adult, again it will be considered as a threshold for PCOM if using older technology or image quality is insufficient. So all these things, they were considered neatly in the ESHRE 2023. Then question comes, till 2023, those who were having 12 to 13 follicles, they were labeled as PCOM, they were labeled as PCOS and so treated. Now 20 came. Actually, if we read the minutes of the meetings of ESHRE, almost more than half of the researchers, they were saying that it should be 25. Then only you call it as PCOM. But then again, there was a compromise. I am using these words online very carefully. They used the compromise. And then it was said कि पहले 12 था अभी 25 ने 20, no problem, 20 रखेंगे. This is how it has come as 20. Now all our maximum criteria till this moment, we have come to know that almost all are based on consensus meetings. That means polycystic ovary morphology, oligoovulation, anovulation, high androgens, androgenic features, obesity, insulin resistance, high unopposed estrogen, and mild high prolactin, all of them can be there, or there can be different combinations in our patients, and all of them, they should be considered as polycystic ovary syndrome, because one patient may have polycystic ovarian morphology but not the androgenic features, but may have high androgenic biochemical levels or vice versa. And this is how the only fraction of those with polycystic ovary appearance, they have clinical and or endocrine factors of PCOS. Means all PCOM are not PCOS. Second, these are the facts. A polycystic ovary appearance is found in 23% of women of reproductive age group. That means those women are normal. They do not have PCOS. Estimates of PCOS in such is 5 to 10%. Means amongst the 23%, only 5 to 10% they will have PCOS. An English study showed that only polycystic ovary appearance is not associated with impaired fecundity or fertility. And now my question to all of you, that when a patient comes with the report of polycystic ovary morphology, she says that कि मैडम मेरे 2-3 महीने तक मेंसेस अच्छी तरह से नहीं आ रहे, दे आर गेटिंग डिलेड, बस वो दो चीज़ों पे आर वी गोइंग टू पुट देम ऑल on metformin, on anti-androgens, or on OC pills? So answer is no. It's confused. Obesity. In between papers came, everybody started saying that ki obesity is like anything and it occurs with more than 50% of the patients with PCOS, especially the central android obesity. Again, high waist to hip ratio, insulin resistance, increased risk of diabetes and CVD. Do you know the facts? Obesity occurs in more than 50% of the patients with PCOS, but again, the percentage of obese women with PCOS, it varies from east to west. Means our obese women, they will have less PCO than the Western women. Is it so? From 20 to 60%. But again, in our studies, we found out a very different population. There was a good trial, that was mapping trial, metabolic assessment of polycystic ovaries in India. I was a part of it. We conducted it in the southern part of the India, and there we found out that all thin, lean women with all normal endocrinological factors, but high androgens, they were having very resistant PCO. Many of them, they were on single carbohydrate diet. In our area, we do not have McDonald's at all. We do not have such fancy food items and all at all because it's a hilly area. But still, the PCOS is increasing without obesity. So that means it started thinking, ki, "Arey, what is happening?" Low grade inflammation, yes. Nowadays they are saying that. And that's why, if you remember, even while developing the Justosi score, actually, madam told me that somebody misconceptualized us. We have taken it from some of the guidelines. But no, there was a very much great thought process. And that's why purposefully, even I have done obesity in Indian women, when BMI is more than 30, I have put it as a mild criteria. And for Indian women, when obesity BMI goes more than 35, I have taken it as a moderate risk factor. The reason is that the low grade inflammation, yes, that is emerging and crucial factor in PCOS, and all these factors, this is associated with increasing the risk of all these insulin resistance and whatnot. Then the science went ahead and they found out that what causes low grade inflammation? Smoking, poor diet. So it is not only the obesity, but it is the poor diet, the wrong timing of the diet, or the sahi timing but wrong khana of the diet, wrong sleeping time, or khana or sleeping ka wrong time, all these things, they cause the low grade inflammation. Alcohol consumption, which is on high rise nowadays in females, weight gain, stress, and sedentary behavior. All these things are causing low grade inflammation. So, because it is associated with obesity, we thought that only obese women will have PCOS. It is not so. Now, there is very interesting finding. It is the altered gut flora because of this low grade inflammation. The unhealthy diet, lifestyle changes, they cause gut dysbiosis, and which gives persistent inflammation, and that may lead to insulin resistance and hyperandrogenism. Now somebody will say, you are saying unhealthy diet. Yes, I'm very proud here to mention that I work even with one of my veterinary researchers as well. And we have found out that even this polycystic ovary syndrome or the polycystic ovary morphology is again in high rise even in weights. So that is very interesting. Today I'm not going to talk on that. But yes, parallel we are doing studies with even on weights, and that is on high rise. It is the unhealthy diet or what we are giving to them as a garbage. Probably it is causing something in them as well. Coming to the concept of insulin resistance. In obese, 30% of the polycystic ovary syndrome, they have impaired glucose tolerance. In non-obese, 10% of the PCOS, they have impaired glucose tolerance. Not in all. So, are we classifying based on HOMA index GCT? Metformin is not for all. Means, it is my question to all of you. It is written in all textbooks, in all guidelines that please do not use fasting insulin. It is to be done only in experimental settings. Why? Because when we did it, there is a beautiful study I am doing, and that is air pop study. It is assessment of insulin resistance in polycystic ovary patients. Study phase 1 is going on. It has started since 10 July. And what we are doing? Adam, we are comparing GCT, that is glucose challenge test, with HOMA index, with HbA1c, and in association with the acanthosis nigricans, presence of acanthosis nigricans, and lipid profile. And आई एम वेरी मैं इतना आश्चर्य हूँ कि almost in more than 50% of the patients, there is nothing like insulin resistance. But still many of the patients, they have all those clinical parameters or all those clinical signs and symptoms. So there is something different in this, and which we are not seeing in a proper way. What happens in between? Some pharma will come and they will say, now there is great insulin resistance. Suddenly all conferences will start talking on that. Suddenly the usage of metformin will go on high. 5 years have gone. Again conferences came. Everybody started saying metformin is useless. Now again conferences have started and they are saying that, oh, metformin is good when it is given in combination with blah blah blah, like berberine, chromin, then no, so many things. So we have to be very careful, and we have to assess our patient with either HOMA index or GCT, and then found out that whether my patient has insulin resistance, metformin will act. Otherwise, my patient will not have any action with metformin. I think last 4 or 5 slides. Abnormal lipoproteins. Yes, it is my sincere request to all of you, whenever any patient with polycystic ovary comes to us, it is our duty to check these things. Abnormal. We have to do the lipid profile because we are saying it's a metabolic syndrome. And again, whenever I talk on anemia, I always urge along with CBC, please do TSH and lipid. Whenever I talk on hypothyroidism, I say please do CBC and lipid. And whenever I talk on PCOS, I say please do CBC along with lipid profile and thyroid because they go by hand in hand in Indian population. Total cholesterol and TGs they are raised and LDL, HDL they are low. And why this is important? This is important not only उसे आगाह करने के लिए कि आपको आगे CHD होने वाला है, but it is mainly there will be altered drug kinetics and all our drugs, whatever we are using in infertility or in endocrinology, they are oil soluble. So there will be altered drug kinetic. And that's why it is happening. We all know there are only 4 or 5 medicines on this earth for the management of infertility, but some doctors have good success and many they do not have the success because those who are working on all of these parameters they will get good success. So we have to see the patient as a whole. This metabolic syndrome, this is havoc because we did a simple pilot study and in our OPD we found out that because I practice IVF at different areas, one in my place where we have a very rural population, another is in Pune where there is a metro population. So absolutely opposite population, and I am finding this metabolic syndrome in both populations, with McDonald and without McDonald. Waist more than 35, TG more than 150, SDS less than 50, and blood pressure we have to use newer ISSHP guidelines, and the criteria should be 130/85, 135/85. I'm sorry, here I have written. And fasting blood glucose, 2-hour GCT. Dyslipidemia may be seen up to 70% of the Western population. What about us? We have gone through, we have done the pilot study, it's on high rise. So, individualization must be done. And we cannot prescribe OC pill to all. We cannot prescribe anti-androgens to all. We cannot prescribe metformin to all. We cannot tell them that you should go for laparoscopic drilling to all. We cannot tell them exercise for all. Yes, exercise for all for good health is fine. But for the management of PCOS, we have to be very clear because different combinations may be present. We have to understand. We have to explain. We have to involve the patient, involve the family, and plan accordingly. Because suppose patient comes with high androgens. Again, madam, this is a very dangerous population because I have seen those with high free androgenic index and bio-T, that means bioavailable testosterone. What will be the best combination? Here again, the OC pills we have to use, but again with anti-androgenic progesterone, then a special anti-androgenic drug, then metformin, high protein, exercise and yoga अभ्यास. Again, just एक योगा करो या सूर्य नमस्कार करो, ऐसे करके हमें नहीं छोड़ना चाहिए, but we have to tell them which has to be done. There are beautiful studies. There is good study which has shown that the Brahmari pranayam that gives a very good stimulation to the pituitary gland if it is done daily 5 to 10 minutes, in a proper way. And madam, we have one arm of our patients where those who are doing Brahmari only for 3 months, menses are being regularized. So it is possible. Only thing, we have to be very careful. Many a times it happens that we do not do the androgen levels. Only when we see the patient with androgenic features, we are doing the androgen levels, which is a wrong thing. Because that's why I said expression of the high androgen in the form of hirsutism, in the form of acne, may be there, may not be there, because our population is a mixed population and different enzyme levels. If you remember the production of testosterone from the cholesterol, if that cycle then there are so many 5 alpha, 12 beta, and so many 70 hydroxylase, so many enzymes are there, 2 beta HSD and all. So this is a thing that we have to keep in mind. Patient may have clinically hyperandrogenism with normal androgens, or with high androgens, patient may be even normal looking. And in such patients, if we correct the androgens, immediately the patient will get good result in the form of either fertility or the regularization of demences. Last two slides. Proven insulin resistance. If insulin resistance is proven either with HOMA index or with GCT, the best are the insulin sensitizers to shift the endocrine balance. And we have to correct the biological clock by shifting the food times. We are talking about ये मत खाओ वो मत खाओ. No, we have to tell them क्या खाओ और कौन से टाइम पे खाओ. And that's why we have a dietitian in our clinic. I do not call her as a dietitian. I call her as diet designer. And all the women, they get attracted. Oh, she's giving some design. So we tell all the women कि आप क्या खाती हो, आप जैसे खाते हो वैसे लिखो और 4 दिन का लिखा हुआ आप हमें ला के दो. We will do the corrections. Otherwise, it is very difficult to change a diet of any single woman because she has lot of work, lot of responsibilities and all. So we make some changes in that. So that is very important. Last week I was with the Tata cancer specialists and researchers, and madam, I got an insight. They said that sugar is next tobacco. So that was the sentence which was used by the researchers of the Tata cancer, and they found out that with high glycemic index foods, not even with obesity, the cancer, the cancer problems, the treatment failures, they are high with high glycemic index foods. So that we have to be very careful, and that's why, if you remember, in the management or in the prevention of hypertensive disorders, there is first line in the Glycamagar approach, and that is low carbohydrate foods. That is the reason. Now, identification of Cushing syndrome by the clinical or 24-hour urinary free cortisol, overnight dexamethasone suppression test, and if required, endocrine consultation. Again, this overnight dexamethasone suppression test, etc., all these things we can conduct at our clinic, because what we have done, हमने छोटे छोटे पर्चे बनाए हैं. कितने बजे खाओ, ये गोली कितने बजे खाओ, इतने बजे उठो, अलार्म लगाओ, इतने बजे क्लिनिक में आ जाओ, इनको फोन करो तो ये आपका ब्लड ले लेगी. सुबह जल्दी आना है तो इनको फोन करो. It's very easy. No need to send our patients, all patients, to the endocrines. Congenital adrenal hyperplasia, yes, it is though less, but in India it is common. Again, 4 in 11,200. I have seen one patient of adult variety congenital adrenal hyperplasia. This is AOAH. Early adulthood, sudden changes in the androgenic features. Such patients have hypoglycemia, hypertension. Again, I would like to give you a hint here. Whenever any patient with hirsutism or hyperandrogenic features comes to us, it is our duty to check her blood pressure again and again, because she will give us the idea, oh, she might be the adult variety adrenal hyperplasia. Usually these patients, they have cystic tendency, and 17 OHP is high. Again, ACTS stimulation test, that will give the confirmatory result. Lastly, androgen secreting tumors. One must not forget that adrenal gland is there, and that is also contributing for the androgens. It is not only ovary which is giving the androgens. It is the adrenal gland, she is also giving androgens, and a good abdomen pelvic sonography has to be done to rule out any pathology, maybe inside the adrenal gland or something compressing the adrenal gland, that will alter the physiology of the androgens. not touching AMH at all, because again, all researchers, all guidelines, everybody has come to the conclusion that AMH, anti-Mullerian hormone, all Mullerian inhibitory substance, it is, I should not use this word, but really it is useless thing in the diagnosis of polycystic ovary syndrome, in the diagnosis of premature ovarian failure. It gives only idea about ovarian reserve. And many of the clinicians, many of the IVF consultants, they are jumping to some conclusions and the diagnosis depending upon the AMH, which we have done a study where, madam, 88 patients they were enrolled in the study. We saw on day 2, we saw on day 16, and there are great variations. Again, I should not say this, but you are very respected, so I will, ये मेरे मन की जो खंत है मैं ये बोलने जा रहा हूँ. अगर ये AMH कोई जनरल प्रैक्टिशनर करता है तो ये बहुत ज़्यादा आता है. कोई लैप्रोस्कोपिक सर्जन करता है तो ये ज़्यादा आता है. कोई IVF वाला करता है तो ये कम आता है. और कोई रूटीन गायनेकोलॉजिस्ट करता है तो ये नॉर्मल आता है. ये ऐसे क्यों हो रहा है? मैंने आई हैव सच डेटा, आई हैव सच फाइल आई हैव मेंटेन कि सेम AMH सेम पेशेंट का अलग अलग पैथी वाले करेंगे तो अलग अलग रिजल्ट आता है. एंड दैट्स व्हाई आई एम नॉट टचिंग दिस AMH एट ऑल, बिकॉज देयर आर सो मेनी डाउट्स प्रैक्टिकली, variations, blood collection, transport, methodology, reporting, real implications, and the correlation with day 2 FSH and AFC, it is not there. We have a beautiful study which was published, that is mother study, with myself, then Dr. Sonia ji, then Dr. Charmila, and so many researchers were there. And we have also found out that it is the day 2 FSH and day 2 antral follicle count, they are more sensitive markers than the AMH. So I hope I have not confused, but I have tried to show the facts that whenever we are saying or uttering that it is polycystic ovary syndrome patients I am dealing with, in them either we have to do all the investigations in a proper way, on a proper day, with proper precautions like fasting, PP, the time of understanding the physiology of the hormones. Yesterday it happened, madam. One patient came to give TSH. She came at 4 o'clock in the evening. It came 10. I was surprised. She's taking proper tablets. Everything is fine, fantastic. Her pulse, BP, everything is normal. I said, no problem. 4 दिन जाने दो. Come early in the morning with fasting status and let us see. And it came normal with same lab. So even we have to be very careful that whenever we are doing in a hormone the investigations, we have to keep all the diurnal variations in our mind, all the physiological changes in the hormone in our mind. And then that's why I have made a simple habit. Whenever a report comes in front of me, I put this blood sample was given on this day of the cycle and patient is on these medications. So then our mindset will change. Okay, she's taking these things and that's why there might be some or little variation in the report. And then only we can give the correct treatment. Otherwise, what is happening to the infertilologist? I have 3 centers, but still I am also part of that faculty. But I will say what is happening, they are moving with the machine gun. जिसका गोली लग जाए उसका लग जाए. And then many of them say कि अरे मेरे ट्रीटमेंट से इसको प्रेगनेंसी रहा. I don't think it is the nature who corrects all these things. We are helping them. So we have to be very careful while phenotyping and uttering the word polycystic ovary syndrome. And again I repeat the word of Professor Royenberg. It has less to do with the ovary and it has much to do with the other metabolics. So I'm very much thankful for patient listening, and I'm open for discussion, and please correct me whenever I am wrong. Thank you very much. Thank you very much.
Thank you so much, sir. It was a beautiful insight on PCOS today. Thank you. Ma'am, your comments? Dr.
My
Sharda, ma'am?
comments are for the first time after
My
hearing
comments
Dr.
are for the
Gorak.
first time after hearing Dr. Gorak.
There's something wrong. My sound is echoing, I think, Dr. Gorak, you have confused us more after your presentation. This is what I feel about it. I think, my fundamentals were pretty clear, but after listening your talk, they have gone haywire.
Right.
You have, we believe that, there are two entities, obese PCOS and thin PCOS. And thin PCOS also have, when they have PCOS, they are terrible to treat. That is also there. One thing is also very clear. I also believe, like you, that, unless your insulin resistance is documented by 75-gram glucose test, do not give metformin. It will not work. This has been told to be by another endocrinologist, and he also said that कि मैडम जब तक कि आपका 75 ग्राम ग्लूकोज में रेजिस्टेंस इंसुलिन रेजिस्टेंस नहीं आता, मेटफॉर्मिन आप पेशेंट्स को नहीं देना. तो आपने जब तक 75 ग्राम ग्लूकोज से आपको ग्लूकोज इंटॉलरेंस नहीं पता चलेगी, तब तक हमें इस ट्रीटमेंट को देना नहीं है. With the people who are less than 140 after 75 gram glucose level, it is not to be given. बिल्कुल क्लियर है. PCOS जहां तक I am concerned, 50% of the treatment is weight loss. She has to normalize. And आपने ये जो normalize वाली बात है, ये proportion में बहुत होना बहुत जरूरी है. लेडी के लिए 36, 24, 36 ये proportion है उसका. कमरा नहीं होना है उसका. I also give lot of weightage on कमर में जो है कि आप जब तक कि कमर को अपना हाइट से आधा नहीं करोगे, इसके ऊपर हम लेडीज को बहुत काम करना है. I think it is just like a Kegel exercise. I think right in the school itself it should be told to people कि एक Kegel exercise आपके लिए बहुत important है. कब बताते? डिलीवरी के बाद, और फिर जब मेनोपॉज हो जाएगी, उसको स्ट्रेस इनकॉन्टिनेंस होगा, तब Kegel exercise बताते हैं. That's not the time. So what I feel is इस कमर के बारे में भी हमें तभी बताना चाहिए कि यू शुड लुक लेडी लाइक. ये कोई बात नहीं कि आप अपने कमर को कमरा बना लो. बट मेरे आपके फंडामेंटल्स आपसे क्लियर नहीं हो पाए अबाउट द ओसीपी. क्योंकि मानिए या नहीं मानिए, पेशेंट कम टू अस मोर देन 50% ऑफ टाइम विद डिलेड पीरियड्स. अभी 1.5 महीना हुआ तो मदर बॉदर नहीं करती, 2 महीना हुआ मदर बॉदर नहीं करती. मदर बॉदर करती है जब पीरियड्स उसके 4 महीने, 5 महीने, 6 महीने हो जाते हैं. दे दमसेल्स कम एंड से, मैडम ये लड़की से लड़का होने जा रही है, कुछ करो इसका.
राइट.
तो एक बात बिल्कुल क्लियर है. एंड आई फाइंड दिस हाइपर एंड्रोजनम फीचर्स आर सीन इन माय प्रैक्टिस 25%.
Yes. Great.
25%. And you find there are good kind of people who have everything. इतने मोटे होंगे, सारे फीचर्स उनके होंगे, पीरियड्स भी उनके लेट आएंगे, बाल भी उनके ज्यादा हैं, एक्ने भी उनके पास है, सब कुछ है. ये they are the worst combination for me to treat them for infertility.
Yes. That's why I said, madam, कि जो लास्ट में मैंने जो
ट्रीटमेंट नहीं समझ आया आपका, ये आप क्या कहना बात कर रहे हैं.
राइट.
ट्रीटमेंट को क्लियर करिए एक बार दोबारा.
ओके. ट्रीटमेंट का मैंने इसलिए मैडम ये बोला कि whenever patient is in front of us,
सर quite a few of us are infertility expert. अपनी टिप्स भी दीजिए. आप 3 आईवी सेंटर बनाते हैं और आप प्रेग्नेंट से नहीं देंगे तो आई एम यूजलेस. हमें तो प्रेगनेंसी की कोई टिप दीजिए ना.
राइट. एब्सोल्युटली. तो नंबर 1, whenever patient has come in front of us and we are very clear, yo, she is obese and she has all those hyperandrogenic features, etc. In them, number 1, as you said rightly, we tell them you have to reduce the weight, and that to 10 to 20% of the current weight. That to a programmed weight loss that will be on 2 to 3 months. Number two, we have to give OC pill, but one thing we have to keep in mind that consecutively, if we give OC pills for more than 2 months, then we are going to downregulate her. And even there will be problem at the levels of the receptors. And again, such patients, when we take them for stimulation or even hyperstimulation, like what we do in IVF, there will be a very uh, unsure response. And that's why whenever we are using OC pills, we should not use for more than 2 months consecutively. Third thing, whenever we are using the OC pill, again it should not be with androgenic progesterone, but it should be with anti-androgenic progesterone, like either cyproterone acetate or drospirenone.
Prosperinone.
Because they, especially again drospirenone, because again drospirenone, that helps a lot even in reducing whatever that small kind of edema, etc., with the patient, because that will cause the reduction on the androgen load. Next thing I want to add here, we have to use anti-androgens in a proper way, like finasteride or flutamide, or even plain cyproterone, or even plain lacilactone,
Electron.
we say spironolactone, because that is very important. Many a times it happens that our colleagues, infertologists and gynec colleagues, they fear to use the anti-androgens. One should not do that. In fact, I am of the opinion that many thin, lean patients, they have high androgens. And if we use the combination of OC pill with drospirenone plus flutamide plus high proteins, because again here I would like to say many a times we are not doing SHBG, sex hormone binding globulins are not being done. And ये आश्चर्य की बात है कि ये सब पेशेंट्स में वो बहुत नीचे गया होता है. So if we add the high protein diet along with flutamide, along with drospirenone wali OC pill, along with exercise, then probably it will give us a very good effect in reducing the overload of androgens in both obese as well as thin lean patients. मेरा ये फिनोटाइपिंग कहने का मतलब ये था कि बहुत बार ऐसे होता है कि whenever patient comes with the report of PCOS, उसे तुरंत एक फोलिक एसिड की टैबलेट, एक मेटफॉर्मिन की टैबलेट और एक ओसीपिल की टैबलेट पे भेजा जाता है. It should not happen. And we have to understand कि whether my patient has metabolic upset, if it is, adding metformin or adding myoinositol, adding berberine. But if she doesn't have, it is not going to help, and unnecessarily we are disturbing her liver like anything. That is the concept. Next thing I would like to say here, two types of patients will come. One, they will come for fertility, then we have to normalize them and then take for IVF or IUI cycles. Otherwise, it has happened कि high testosterone level and rest all things are fine, and then we have done the IVF, and many a times they go on missed abortions, recurrent abortions. Again, it is the high testosterone which is back of the in the inside. So that we have to keep in mind. So unless until we correct her, normalize her, one should not take them. Second patients, as you rightly said, madam, they will come for regularization of menstrual cycles, or they will come for the complaint of menorrhagia, or they will come for the complaint of chronic anovulation, or they may come only for hirsutism and acne. So in them, how we are going to treat? So here again, we have to check whether she has insulin resistance. If it is, metformin will act like anything. But if it is not, for how long period are we going to give OC pills? Because there is a great research which has shown that if we use OC pill for long time in such patients, there will be hampering of the breast development of all these girls. And that is a big problem. Again, we are increasing unnecessarily, exposing them unnecessarily to the high levels of estrogen. Though we are saying them low dose OC pills, we have so many patients that with 3 or 4 tablets, patient have gone in sigmoid sinus thrombosis because those who are genetically provoking. So here again, if we use OC pills initially for regularizing the cycle, as well as for reducing the androgenic load, later on we have to shift these patients to non-androgenic progesterone withdrawals. So say for example, the beautiful drug we have lost in or we are not using much in the youngsters is medroxyprogesterone.
Definitely.
And again a 19-nortestosterone derivative. So we can use these drugs for the withdrawals. Only problem of this drug, medroxyprogesterone, is late withdrawal. But fine, if we tell our patient that please take this tablet from day 21 for 5 days and your menses will get regularized, forget it. And if you want a permanent result, go for exercise. But if we use OC pills again and again, we are dysregulating her HPO axis. We are dysregulating her receptors. And again, I am putting here not a theory, but an observation. The years of menopause, they are approaching early. One of the reason is again, not only it is the early menarche, not only it is only thing, but it is the over usage of the OC pills. So here again I would like to add the word erratic and over usage of the OC pills. That is again causing the dysregulation of these receptors. And that is the thing what I want to say. We have to identify our patient, what is her need, and only that much treatment has to be given. That was the concept. Again, I would like to add here the role of OC pill in the PCOS patients before the IVF. If we want to reduce the incidence of OHSS, if we want to reduce the incidence of cycle cancellation, then irregular follicles, we have to use OC pill 1 month prior the cycle. Because if we use good OC pill with drosperinone prior the IVF cycle, the next cycle, we will get a synchrony of the follicles, good number of the follicles, and there will be less incidence of the OHSS if we are using antagonistic cycle here. So this was the idea of this talk. We have to identify the need of the patient. We have to identify the nature of the patient, because madam, many patients, they have polycystic ovary morphology, but hormones are normal. Only TSH is deranged. Only prolactin has gone deranged. And because of that, she has menstrual irregularities. So almost 20 to 22% patients, they have gone. Rest 20 patients, as you rightly said, only they have polycystic ovary syndrome. But many a times, a routine gynecologist, it is with her, it is happening that every patient is taken as polycystic ovary syndrome, and we are starting OC pills haywire. And that cough should not be there. That was the idea. Over to you.
Sir, I think you gave a lot of insight. I'm just taking others' time. One thing is also, I'm also very fond of people who do not have hirsutism. After the cycle control of, people have had a 4 months or 5 months, I feel, these patients, cyproterone acetate, I'm very fond of, though modern literature says कि ये वाला brand नहीं use करना चाहिए, but मेरे जैसे लोग Jeanette 35 पसंद करते हैं डॉक्टर साहब. So I like that. And once I find they do not have much of hirsutism, मेरे जैसे लोग तो मैप्रेट देते हैं, that is medroxyprogesterone acetate, 3 दिन में टैबलेट देती हूँ सुबह शाम, पेशेंट बहुत खुश, उसको पीरियड जाते हैं, फिर मैं उसकी मम्मी को कहती हूँ भैया इसका थोड़ा सा 2-3 बार विड्रॉ करके देखो अगर इसको अपने आप पीरियड्स आने लगे या नहीं, बाय दैट टाइम शी हैज नॉर्मल वेट। नाउ सेकंड, ये ड्रॉस्पेरिनॉन का कौन सी प्रिपरेशन यूज करते हैं आप in IVF cycle?
Dronis 30.
Donis. We usually use Donis 30.
अच्छा,
Right. Because it has lesser side effects in the form of acid peptic disease. It is very less.
But you also mentioned about, patients of sometimes they have a menstrual problem, sometimes they also hyperandrogenism, and you find that these androgens are raised, and we give them OCPL plus we give them. I am fond of giving Aldacton 50 milligram BD. Somehow हमारी ट्रेनिंग नहीं हुई है, उसको किसी ने अच्छी तरह से डोज नहीं बताई है, तो हम तो 50 मिलीग्राम बीडी पे स्टक हो जाते हैं। फ्लूटामाइड जैसी चीज तो हमने कभी यूज ही नहीं की, आप जैसे लोग को सिखा देंगे तो शायद उसको यूज करना शुरू करते हैं। I find people have androgens, those people are, it is a wonderful combination that you give an OCP along with Aldacton. मैंने कभी फ्लूटामाइड वगैरह कुछ यूज नहीं किया, उसके बारे में भी throw some light on people.
Yeah, no, it is Aldacton is better, but madam again, if we see for the ovarian androgens, best is flutamide. And because again, only problem about flutamide is if we use with high doses and for consecutive more than 2 months, then it has a tendency to produce little depression. One. And second, in the thousands of patients, I have found only 2 patients with jaundice. Only 2 patients, 2 out of 1,000. But it is written specifically that it is a enzyme inducer. So maybe use cautiously. But 2 in 1,000 is really less incidence. But if we use flutamide, 250 milligram BD initially, and later on OD, along with this drosperinone valley tablet, and along with high protein diet, it is working like anything. Because all things are getting care of. With the OCP, SHBG will increase. With drosperinone, androgens will go down. With flutamide, androgens will go down. With high protein, again SHBG will increase and available testosterone will be less. So all these things, they are taking care of. So it is that way very, I will say it has good safety profile.
It is open, Dr. Shakuntala, Dr. Kiran, Dr. Sujata.
Sir,
Dr.
I have a question.
Saratoria, please make a
Yes,
comment.
Sir, I have a question. For how long we can give Aldacton? If we are using Aldacton along with the OCPs, for
Okay.
how long we can continue?
Definitely, madam, we can continue till all these androgens, they go back to normal.
Normally, sir, but
normally-
normally when we
normally
get the
we-
test
we-
done,
yes.
the reports are normal.
Yes.
When normally we get the test done, reports are normal, but the patient is having lot of hair on chin and on the sides of these.
Correct.
We have to then add Aldacton. So
Okay.
for how long I was asking for how long we
Okay.
can give.
Okay.
Because somewhere I heard it up to 2 years we can give it safely.
Yeah.
Is it
Yes.
true?
Yeah. Number 1, madam, if patient has come to you for the skin problems, then definitely you have to use for long time. There is no problem. But what is ideal treatment? Ideal treatment, we have to start the anti-androgens, check the levels. If the levels are normal, take the help of dermatologist, then do all whatever procedures they want to do. Again, continue the anti-androgens for at least 2 to 3 months. One thing we have to keep in mind, one hair growth total from bottom to top, it takes 6 months. So it will take again 6 months to go back. So minimum 6 months treatment, if she is coming to us for the dermatological problem, we have to give. But when she is coming for fertility, and our observation is that oh, she has this problem, then when the levels are normal, we have to stop it. In fact, when we are doing stimulation, all anti-androgenic drugs, they should be stopped and then only we have to start our treatment. But the answer is yes, for dermatological problems, minimum 6 months. and then depending upon. But in between, we have to take the help of dermatologist. In our clinic, what we are following, 2 months anti-androgens, exercise, dermatologist, and again 2 to 3 months of anti-androgenic drugs. Patients are very happy that both the treatments, right from bottom to they are clear.
So do you think they do laser therapies usually for hair growth? So do you think the hair goes away with this laser
Yes.
therapy?
No, no, madam.
No, but
They
patients
never go.
always
Yeah.
patients come and complain that they don't go completely.
No, no,
Yes,
no,
madam.
no.
They will never go. They will never go
No, no,
completely.
the
Hair follicles will stay, no?
existing follicles,
So
Because
Hair
hair growth
follicles.
doesn't go
existing
up
hair
laser as
follicles,
well.
they are destroyed, but new can
Yeah.
grow.
see,
With
hair follicle is
Eldecton,
there.
new hairs don't come. With Eldecton, new hairs don't grow, but old
No.
they get suppressed.
Now, only thing I would like to hear add, we reduce the sensitivity of that hair follicle of the androgens by using
And-
anti-androgens.
Correct.
That's it.
Right.
Hmm.
So hair
So
follicle
thinning.
is there, तो hair तो आएगा ही आएगा. Only thing कि जो एग्जाम्पल है मैं देखिए बोल रहा हूँ कि जो 1 महीने में आने वाला था वो शायद 6-7 महीने में आएगा. So that
Okay.
sensitivity we are reducing. So as Madam Vandana ji has said, because hair follicle is there, तो hair तो आने वाला है.
नहीं
It is
hair तो
only मैं
आएगा
इसी
भी
को
sir. It's only thinning of the hair with
yes,
us
it is a
giving these
thinning of the
anti-androgens, and there has to be a spacing between us stopping the anti-androgens and inducing the patient,
using the
because we want the anti-androgen levels to go down. So
to
at
go.
least I think at least a month's gap should be there.
Yeah, ideally it has to be.
Exactly. We must target what we want from that particular patient, what is required. Because PCOS is like a spectrum, you very rightly said, sir. So a PCOS with infertility management will be, different,
Infertility.
and a young PCOS adolescent, it will be different. For hirsutism, it will be different. So we have to, individualize the
Target.
treatment. So one point I just wanted to add was you talked about depression with flutamide. I think all patients of PCOS need to be screened for mental health and
Depression.
eating disorders and disordered eating. These things are very, very important.
These
So,
are
what is
very
your comment regarding that? Mental health is also very important because it is seen that a lot of PCOS girls have endogenous depression.
yes, madam, and that's why I put in the slide कि it is not only we have to talk about food habits, but we have to talk about the timings of the food, for how much time they should eat, what should be the spacing in between the foods. So all these things they will come, and that's purposefully I said one line, adjusting the biological rhythm, because
True.
that is the main culprit in these patients, that they are getting up in 10 o'clock, 11 o'clock, they are
Yes.
sleeping at 2 o'clock and all. So all this is disturbing the endocrinology. So we have to
Certain.
counsel them.
So am I audible?
Yeah, Sujata, you
Yes,
are
yes.
audible.
Go ahead.
Okay.
Yeah.
That was really wonderful. I just want to thank you for highlighting importance reading ultrasound correctly, when to level PCOS, not to treat all the patients with multiple follicles. Number one. Number two, we should not do ultrasound in young girls because ovaries are already uh, multicystic. And
Multiple.
number
Yes.
three, should we not do? I have seen so many reports of insulin, and all are normal. So should we not do insulin in all the patients? So this should be a
Yes.
take-home message.
Yeah.
इंसुलिन नहीं
Even,
चाहिए,
even
75 ग्राम ग्लूकोज करो.
Yeah.
yeah,
So we
simplest
should all
idea.
do 75. So
Yes.
no more insulin fasting PP, ma'am. So many patients are coming with all these reports, and every
Right.
time all reports are normal.
Correct.
No, they
And that's why the
are.
simplest idea here I can give, as madam has rightly said, GCT
Yes.
we can do in 50 rupees. Right? 50
Yes.
rupees what sachet ka, 50 rupees taste ka. Another thing, those patients having acanthosis nigricans, those are the patients where we have to do the insulin levels.
Correct.
Second thing, as madam was rightly saying, those with high hip to waist ratio, there again we have to check whether it is only the obesity or it is the
Insulin resistance.
obesity with insulin resistance, because again the management will differ.
So we'll be doing a GTD to find out insulin resistance,
GCT
not
2
the
2
insulin
hours.
ratio.
हाँ बस
Yeah,
जरूरी
yeah,
नहीं
yeah.
है.
Because
Initially
Shakuntala,
GCT.
Shakuntala, your comments?
Yeah, thank you very much, Dr. Gaurak. It was very enlightening. And with the types of, with the phenotypes, the PCOS phenotypes, those two classic varieties, then we have the ovulatory variety and a non-androgenic variety. One thing that you highlighted about the diet I must tell you, this statement of yours that sugar is the next tobacco, I think we should print it in bold and we should talk about it. It is something in an endocrinology meet. What happened? One of the endocrinologists' mother had ovarian malignancy and she was diabetes type 1. He narrated this story very, very affably. He said that my mother had chemotherapy following the surgery and she was given diet she could not eat. So her diet reduced from 1200 calories to 1000 calories to 800 calories to barely 500 calories. From type 1, she became type 2, and from type 2, she became normoglycemic. So what he highlighted was that a proper diet can reverse diabetes. What to talk about PCOS? Now, if we eliminate sugar from diet completely, and if we customizing the diet, when you talk about the diet design,
yes.
Even we have a dietitian. पहले तो मैं उसकी क्लास लगाती हूँ, बैठ के उसके साथ बैठती हूँ, उसको आधा घंटा नरेट करती हूँ. They have their mindsets and they have their customary beliefs. उसको eliminate करने में थोड़ा समय लगता है. But when we sit down and we design the diet for one particular person, I have seen the results are remarkable,
Absolutely.
And talking about not doing ultrasound in young girls, well, if you do ultrasound in young girls now, and if you see fatty liver 1, at least it's a warning sign. Don't look at the ovaries, at least look at the liver. Look at the stones that our young girls are suffering from.
Yes.
You have to do the ultrasound, not getting afraid by the volume of the ovary. Maybe it is the multicystic ovary, but there are so many other findings which need to be addressed. So we certainly do the ultrasound, we do a thyroid function, we do certain
lipid profile,
very important, and insulin levels. They become our counseling tools, And when we customize the diet, remarkable change in my girls. I mean, this is what I feel.
Absolutely, madam. I absolutely agree, and that's why I said, even in on my all those drug dabbas, we provide drug dabbas to all my patients, and उस पे लिखा होता है मराठी में 4 घास कमी खाऊया, 2 घास कमी खाऊया, 4 पावले जास्त चालूया.
करेक्ट.
इसका मतलब होता है कि 2 निवाले कम खाओ,
4 कदम ज्यादा चलो.
4 कदम ज्यादा चलो. और मेरी कार के पीछे ये लिखा हुआ है. So whenever I go anywhere, the whole city reads that.
If we do this now, sir, if we just train our minds that hunger is good, it has helped me personally.
Absolutely.
I have started training my mind. Hunger is good, Shakuntala, hunger is good. The moment I am hungry, this is good. My, my non-medical brother, he taught me. He said, if you start talking about your diet, sometimes in this age group also you can have release of growth hormones because hunger kills cancer cells. Now, if you have, those rapidly multiplying cells dying because they are not getting sugar, I mean, we are treating so many diseases and we should talk about it.
Absolutely. We should talk about it. In fact, madam, one line I will add. In the prevention of HDP, why we are saying that, stop sugar. मैंने गोड़ हम लिखते ही हैं गोड़ बंद और 2 अंडा रोज. ये when I write that, मैंने out of 200 only 2 patients they were HDP and 198 patients they were not with HDP. All IVF patients data I am talking.
Correct.
So it is possible, as you rightly said, madam. Sugar is next tobacco that we have to underline it.
It's okay, Shakuntala can practice on herself.
No, ma'am.
Also,
Ma'am, it's a proper counseling. When we sit down, we have classes in our clinic. When we counsel our patients, दिल से हम लोग काउंसलिंग करते हैं. और मैं बता रही हूँ आपको मैम, 100 में से मेरे को कम से कम 20 मरीज सुनते हैं और वो आते हैं वापस. मेरी तो एक जीरियाट्रिक पॉपुलेशन में से one of the lady, she has become a yoga instructor in Uttarakhand. Every year she visits me and she gives me tips of how to remain healthy.
मुझे बताओ मैं क्या हूँ. मुझे
मूंगफली थी और वो पॉपकॉर्न्स थे और उसमें चिक्की थी मूंगफली वाली. So she asked me, she gave it to me and मुझे choice करनी कि out of the 3 which should I take, and will you believe it, I took मूंगफली and गुड़ की चिक्की. I'm telling you.
But then you took protein also. You took protein.
सुनो शकुंतला, मैं कब आऊँ मीठा छोड़ने के लिए? Give me a class on that.
नहीं,
Only
और
online.
Gaurav sir, Shakuntala has
और ये
highlighted
भी
very important thing.
दोनों इसके घर जाएंगे
और ये भी हम
नहीं,
आज के
नहीं,
दिन
बताना चाहती
आज
हूँ
के दिन हम बात कर रहे हैं जिस दिन बोला जाता है कि तिलगुल घ्या गोड़ बोला।
मकर
हाँ।
संक्रांति।
नहीं, लेकिन हम
सर
सब
सारा
बात कर
खाना
रहे हैं
बंद
ना,
करा दोगे आप तो
आई थिंक हम लोग
नहीं,
अफर्म कर रहे हैं।
एक चीज ये है कि हमें बार बार अपना मुंह नहीं खोलना। ये वाली
Yes.
चीज यू शुड गो विद एन आइडिया दैट एक बार मॉर्निंग में खोलो भैया, 1 घंटे में सारा ब्रेकफास्ट खत्म कर लो, लंच में खोलो वो 50-55 मिनट में आप खत्म करो, क्योंकि वो जो हवन की सामग्री है ना वो आपके 55 मिनट के बाद दोबारा डल जाएगी। ये बार बार हवन की सामग्री नहीं।
मैम मेरी कश्मीरी न्यूरोटोलॉजिस्ट है, वो उसने अपने बच्चों के लिए मदर को वो ट्रेनिंग देती है कि बच्चों को ना नमक खिलाना है ना मीठा खिलाना है, आप बच्चों को खाना दो ताकि वो खाने का फ्लेवर अंडरस्टैंड कर सकें। एंड
डॉक्टर
इमेजिन
सारे बाहर के सारे पीडियाट्रिशियन यही करते हैं,
जी,
ना तो वो नमक खिलवाने देते और ना वो चीनी
ना
खिलवाने
चीनी। और आप सोचिए ये बच्चे जो है ये नेक्स्ट जनरेशन है मैम, डायबिटीज चली जाएगी इससे। तो ये डायबिटीज और हाइपरटेंशन का यही एक उन्मूलन का तरीका है। यदि हम अपने डाइट को करेक्ट कर लेंगे तो ये दो चीजें हमारी काफी हद तक जो ये हमारा एपिडेमिक हो रहा है ये काफी हद तक एड्रेस हो जाएगा।
अच्छा, लीन पेशेंट्स को इतना पीसीओएस क्यों हो रहा है सर? अगर
हाँ,
हम ये कहते हैं कि दिस इज मेटाबॉलिक डिफेक्ट, मेटाबॉलिक डिजीज, देन
Can I
व्हाई
say something, sir? Can I say something?
Yes.
बाहर का खाना
बिल्कुल, आपको पता है ये लोग क्या करते हैं, पूरे दिन में एक पैकेट चिप्स का और एक कॉफी का लेते हैं और वो लीन है, एक्सरसाइज बिल्कुल नहीं करते हैं, उनकी बॉडी में सारे टॉक्सिन्स हैं, उनकी बॉडी में नेसेसरी एलिमेंट्स नहीं है, दे हैव सार्कोपीनिया एंड दे आर सफरिंग फ्रॉम सो मेनी डिसऑर्डर्स, hence also from PCOS. Lean PCOS are more dangerous, and if you recommend exercises,
They are very difficult to
to
treat.
treat,
very difficult to
very
treat.
difficult to
difficult
treat.
to treat.
Yes.
नहीं, ये चीज है।
एक
और
बार एक ना डाइटिशियंस की वो थी, मतलब उसमें सारे डाइटरी वाले वो थे एक्सपर्ट्स, उनकी आई हैपन टू अटेंड दैट, तो उन्होंने यही बोला, यू आर व्हाट योर बैक्टीरिया ईट। So very rightly said by you, Shakuntala, ki whatever we are eating, whatever we are ingesting, our bacteria are metabolizing that. So that is why gut dysbiosis forms the basis for PCOS also.
another
But what
thing
is the
one
difference
should be.
between PCOS and PCOD?
Nothing.
Nothing. Initially it was said PCOD, but nowadays we are adding it as a
Yes.
PCOS.
Okay.
Yes.
Here I would like
Consultant to consultant variation.
हाँ,
Consultant to consultant.
No,
I think PCOS is a wider spectrum. It's a bigger things. एक छोटी बड़ी अटैची में छोटी अटैची।
yes.
बस।
Dr. Seema Sehgal, you have to make some comment.
And it was really excellent. I really love Dr. Shakuntala, what you told. Actually, but I am little bit disagree about this, ki you should stop eating everything, like sweets and all. I never used to take sweets, but the thing is, you should take everything in moderation. Time is very important. And that is what I tell my patients, that you should be very punctual about. My father-in-law, his HbA1c was just 4. And he used to eat so much of sweets. But the thing was, 8 a.m. is tea, 1 p.m. is food, like lunch. So it was so particular. So I think timing to the body is very important. And intervals are also very important, as Dr. Sharda ma'am said. So diet is very important. And PCOS, definitely, I have to counsel a lot because mothers get more worried rather than the patient itself. They bring their daughters and they say, treat her, isko period nahi aa raha, isko kuch karo. So I have to scold them at loss. I said कि तुम बिल्कुल नहीं बोलोगी, और अभी 12, 13, 15 years, 16 years तक patient ऐसे ही उनको मदद से लेके आ जाती है. It's so difficult, but the counseling is very important.
True.
So that is what, and infertility definitely.
फादर-इन-लॉ की बात और शुगर खाने की, फादर-इन-लॉ और शुगर खाने की बात है. डॉक्टर साहब, ये आपके फादर-इन-लॉ की जीन्स अलग होंगी, पर अगर हमारे जैसे लोग उतना शुगर खा लेंगे, चाहे एक बार भी खाएं, तो नहीं होगा ना. वो जीन्स का फर्क है.
जीन्स का हो सकता है मैम, पर फिर भी शुगर टाइमिंग का बहुत फर्क है.
नहीं
जो मैंने
नहीं,
उनसे सीखा, टाइमिंग का बहुत
आप
फर्क है.
3 बार मुंह खोलो. फास्टिंग आपने कभी लेट ब्रेकफास्ट नहीं करना. खाना उठने के बाद आप 1.5 घंटे में अपना ब्रेकफास्ट कर लीजिए, उसके 5 घंटे के बाद और उसके 4 घंटे के बाद आपका डिनर खत्म हो जाना चाहिए. दैट्स इट.
But again, here I would like to add one thing.
Anyway, I think we should take last comment from Dr. Gorak.
Okay.
Anybody wants to make any comment?
No, ma'am.
Sir.
Yeah, madam, again we are doing. Sorry. Yeah, am I audible? Yeah.
Yes.
Madam, we are doing two things now. We are finding some connection with viral etiology. because it is coming like an epidemic. And second thing, it is the genetics, genetic changes. These are doing something, and that's how we are even at our Green Array Center, Pune. We are doing all those studies, and probably we may get something, as you rightly said. And Sima Madam told about the her father-in-law regarding that. So nowadays there are certain changes which are happening at the genes level, which have changed this. Number one, oncogenesis, and second, the diabetogenesis. And that's how this PCO and oncogenesis both have increased only in last 25 to 35 years.
Yes, definitely.
So that
So
research I
epigenetic
think
changes are responsible. It's
absolutely,
epigenetic.
even epigenetic changes. So all these things are there. So that is the thing.
Like, do you think some chemicals are playing role, because nowadays too much of preserved food patients are having, and too
Yeah,
many
absolutely.
chemicals are used in the house?
So
Absolutely.
they are saying this is
Yes, deos,
nutrigenomics. This is
Yes.
nutrigenomics.
This is nutrigenomics, this is pharmacogenomics.
Yeah.
Nutrigenomics is very important. What
Yeah.
madam said rightly, Lata ma'am, okay, that's what we are working and we are finding out. And many patients we are finding ki, "Arey," even as what Sima madam was saying and Shakuntala madam was saying, we are telling our patients ki, at what time you should eat and how much you should eat, depending upon all those nutrigenomics reports. So that is still
तो खाना तो हमें कम करना ही पड़ेगा, ये तो माननी पड़ेगी।
वो तो काम
definitely खाना तो कम करना ही चाहिए।
खाना तो कम करना ही पड़ेगा।
So thank you very much from my side.
Sir,
for,
thank you very much.
Thank you very
I
much.
hope now
Thank you
I
very
am not
much.
confused.
Let me share with you on the 16th. I'm going to talk on how the controversies in PCOS can be controlled, which frequently asked questions. I'm going to give answer. But what sir has taught, उससे थोड़ा different होगा, ज़्यादा different नहीं होगा. He has been able to, but I'm not going to change my slides in the last minute. I'm going to keep my own slides.
Yes.
I'm going to make the talk in the question answer session, so things become much more easier. So this will be on the 16th at 4 o'clock. Anybody will be interested.
और मैंने ये कहना था वो 19 का रिकॉर्डिंग मेरा हो गया.
Thank you so much.
Oh, thank you, sir.
Wow.
Thank
सर
you,
एक
sir.
बार मैं आपको यहाँ बताना चाह रही हूँ, we have made a Delhi Gynecologist Forum calendar, and on your lecture is there every month on the 19th.
19th.
Yes.
This time instead of 19th, we preponed it to the 14th, but otherwise it will be on the 19th.
Yes.
Every time for all of you to listen to is that we have fixed his one lecture on the 19th.
Very nice. Listening to Dr. Gore.
Thank you so much, sir.
Thank you. Bye-bye.
Okay.
Thank you.
Thank you, everyone. Happy Makar
Bye.
Sankranti. Bye-bye.
भी आ जा, डॉक्टर साहब ऊपर हैं, अंदर हैं।